Actually, what I'm going to do, I need us to leave this and come back in again. Okay, so I'm just going to cross out and then click the link and you'll come back in again. I've just signed in with the wrong name. Oh, evening. Oh, we're live. Okay, that's fine. All right, well, we'll start. I'm not sure if we're live on YouTube. It does seem we're live. So welcome. Thank you for joining us. Let's get rid of that for a start. We went live without me even wanting it. It's fair enough. Okay, welcome. So here we are. Hi, Chris. How are you?
Yeah, I'm well, thanks.
Thanks for coming along. I'm not sure if we're going to be live on YouTube tonight, but we are definitely in Facebook because I can see we're being joined by the gang now. Timothy's here, Mark's here, Catherine's here. You can see the names on the right, Chris.
Yeah, sure.
As I was saying, they're a very friendly bunch. And a lot of them, of course, have heard of you already. Not because you're old, like we've been talking about, but because you're very respected when it comes to having been there and very much formative website. And we're going to talk tonight on the subject of posture, which I'm very excited about. We're just going to let the room fill up a bit. If you're new to this, if you're listening to the podcast, well, it is actually recorded live. And we go out on the Facebook page on Sports Therapy Association. And also normally we go out on YouTube. I'm not sure if we are tonight. And you're joining us at episode 40, which we're very excited about. It's come out of COVID. I was talking to our guest earlier on. One of the good things to come out of COVID is we're all just getting together a little bit more and not being seen as the competition. We're talking a bit more, not just among sports therapists and massage therapists, but also physios and osteos and podiatrists and chiropractors. We're all kind of going, right, we're in this game together now. And we've had a kind of a big, and we still do have a rather large enemy, which is making things difficult for us, but we're going to get through it together. So it's great to see you all joining us live, and we encourage you to do so if you can. I just want to say thank you last week to Mike Stewart, who joined us for a very inspirational episode on pain, and just I'm sure something we'll touch on tonight, where we need to look back and think, have we got the best teaching skills as therapists? It's all very well just kind of learning new tricks and with our hands, but when it comes to helping people in pain, then sometimes we got to think about how we talk to that person and hear what they're saying, and that's basically teaching. It's education, and a lot of us don't have that. You're not just born with it a lot of the time. So thanks, Mike, for that, and it's available on YouTube and on the podcast for download on all popular apps. Right, enough of that. Let's not waste this gentleman's time anymore. Thanks for joining us. What would you normally be doing tonight, Chris?
Normally, I would probably be eating, yes, or probably washing up having eaten. Yes,
I've never had this before. I've had about 6 people kind of suggesting that tonight, by Matt Scar's book, said this might be a bit of a fruity conversation. I think maybe because I put that posture and a bomb and an explosive thing, because it is a kind of a much debated, it was a bit of clickbait there. It is a debated topic.
Yeah.
And things have obviously changed a bit. So I'm hoping that people have fallen for that clickbait and thought, oh, great, this is going to be really interesting. But that's the topic we're going to talk about tonight. And you're running courses at the moment, aren't you? Specifically called posture courses, aren't they?
Well, I run courses all the time, but one of them has aspects of posture in the sort of back rehab side of things. Yeah, posture assessment and where it is now, really. Where it was years ago and where it is now.
This is because I think that's quite a bold move, and I think it's good because what we try and do here, what I try and guide things, is not let the pendulum swing too far either way. And I did like seeing on your website, let's just bring it up here at the moment. If you listen to podcasts, obviously you can't see what's going to come up on the screen now, but let's bring this up here now. I'll put it onto big screen so everyone can see it. So yeah, we're talking about the website norrishealth.co.uk. There's again plenty of information on there. It's a great useful website, plenty of free CPD and just having a look through the blogs. But the courses as well, the posture course is definitely an eye-opener. As soon as I saw some of the myths and misconceptions, I thought, oh, this guy is going to be interesting. We like that. Because as we were saying before, evolving with your thoughts on posture is a great way of evolving as a therapist, isn't it? Would you say that's fair to say?
Yeah, I mean, I think we've got to step back a little bit and say, well, you know, why is posture such a topic? I mean, it's one of these things which is a bit like manual therapy, I suppose. It's gone through, trial by social media, as it were, and I think posture, in a way, represents the changing nature of therapies. And many years ago, if you look at where posture came from, it was military background, stand up straight, and all this type of thing. And then it became sort of medicalized, and sort of became owned by the therapy world, if you like. And it was something, I suppose, that we could manage, we could do something with, rather than the surgeons or the medics. And so if we could say, well, pain was the result of something that we could change, that would empower us. And I think historically that was the case. And certainly when I first trained, which was some time ago, I have to say, I qualified in 1981, embarrassingly before many people who were born who are watching this podcast. But it was the case that we had the book, the Florence Kendall book, and you would go through that book on posture and muscle imbalance, and you would assess things, and you would claim to be doing all sorts of things. And at that time, there was very little research in the therapy world, and that sort of side of things became researched by the likes of Vladimir Janda, Carl Levitt. These people were the gurus at the time teaching, and their work was taken up by some of the physios, Gwen Jull and Carolyn Richardson in University of Queensland, and they would do more and more research. And gradually, as we looked at the things we were doing and used some sort of critical appraisal skills, we learned that, there was some research which supported things, and there was some research which actually threw things out. And that is the nature of therapy in general, isn't it? As we go through, what we know about COVID now, we didn't know a year ago, 2 years ago. And what we know about posture now, and the way it interacts with therapies and the way it interacts with pain, we perhaps didn't know some time ago. And certainly, when I was writing, I some years ago, I've written a variety of books, but I wrote a textbook based around sort of posture and muscle imbalance. And the things that I was writing about then, 20 years ago, were based on the science of that time. And now we've moved forwards, and you've got to be big enough to say, well, some of that was great and some of that was not. So we move on, and progress is made by criticism, as they say. We stand on the shoulders of giants, don't we? And those giants were the Kendalls and the Richardsons and the Julls of the time. And we are very grateful for what they did, but we move on.
So you mentioned one of the favorite topics in posture, and which is still, his name is still kind of raised in most kind of polar debates on Twitter in particular. But Janda, so the famous Vladimir Janda. Let's bring up a little picture so people who are not familiar on what we're talking about, if you're not familiar with the name, I'm sure you're familiar with pictures kind of like this. Let's just bring this up for a sec. If you're listening on the podcast, then we have on our screen, nearly put it on there, we have in our screen the typical picture which you'll see on someone's website. I got this one, I did a search straight away, and it came up where you've got somebody who's standing with their head thrusted forward and kind of kyphotic back, their stomach kind of sticking out. I don't think anyone, well, I'll tell a lie, some people are like that, but it's a very kind of forced posture, which is suggesting that we got weak neck flexor muscles, we've got tight upper back muscles, tight chest, weak back. And when you draw a line to join these things together, it forms a cross. And as Chris has mentioned already, this was at the time something pretty impressive from Vladimir Janda, or Janda, it's the correct pronunciation, as Chris has reminded me. But it's still, well, first of all, that picture that's up there, Chris, how much, I mean, has that had to change over the years? What?
Let's again, we need to look at this historically and say, well, this comes from a profession where initially we were using machines, And it was all to do with reducing pain. And then it became very joint centric, and we were mobilizing and manipulating. And what Yanda did, and together, for a start, he was a physician who then became a physiotherapist, which is unusual. And he was best buddies with Carl Levitt, who had a similar sort of training. And basically what they did is they started beating the drum, saying, look, not everything is to do with joints. We've got muscles in the body, and muscles can be sources of pain. Muscles can be used, and rehabilitation can be used to target pain. We don't just need surgery, we don't need drugs, we don't need magic. We can train these people to become pain-free by rehabilitation, which they're doing themselves. And so he, through research in inverted commas, in that it was his own observations rather than it was clinical investigation rather than laboratory-based research initially. He looked at people and he said, well, when I look at people, I find that they're in pain, they haven't been moving around. And so you would think, well, if they've been in pain for all that time and they've rested, all their muscles are going to be completely lax and deconditioned and no use to anyone. That's not what he found. He said, well, what I find is that some muscles are weak, but actually some muscles are tight. And when you press those muscles, they really hurt. And they seem to be a generator of pain. And so he went through the body and he said, well, let's categorize these muscles, find which ones are tight, finds which ones don't appear to be tight. And remember, he was doing this with his hands. He wasn't at that stage doing it with EMG and things. And he came up with these patterns. And the one that you've got on the diagram there is called the upper cross syndrome. And there was an equivalent one called the lower cross syndrome. So the upper cross syndrome was to do with the scapulae and the shoulders. Lower cross syndrome was to do with the pelvis and the low back. And then he had the layer syndrome, which was to do with going through the body and saying, well, certain parts of the body demonstrate weakness, certain parts demonstrate extra strength. Now, when we look at this, we do find this clinically. There's no doubt that we find this clinically. But if you take a group of individuals and you say, well, okay, does everybody who's got a shoulder pain, do they all have upper cross syndrome? The answer is no, they don't. So we can't say that this is necessarily a cause of a particular condition, but you might, as a soft tissue therapist, come across somebody who has muscle tightness at the same time as muscle laxity in different areas of the body. Therefore, what we have to do is to focus our treatment accordingly, rather than doing a blanket approach, rather than saying, well, okay, this person is weak, let's go get them doing deadlifts and squats. This person is tight, let's go give them some relaxation, some massage and whatever. So it is patient-centric, but it's 20, 30 years ago. So, quite revolutionary at the time, quite revolutionary time. An interesting guy, Vladimir Yanda, because he had polio. And so whenever you saw him lecture halfway through the day, he would lie down on the couch for half an hour, get himself sorted, and then he'd go again. We would call that pacing now. At the time, he just sort of said, well, I'm having a bit of a rest, and I'm resting my hip. So the answer is it is relevant, but it's more likely to be relevant to individual patients rather than populations. So in other words, it's not going to be every person who comes in with shoulder pain will demonstrate an upper cross syndrome. It's not a cause, it is a symptom.
Not a cause, but a symptom. Very nice. Yeah, it's sometimes his name is dragged through the mud by the very kind of like vocally skeptical, but a massive pioneer, like you say, at the time, like so many who had nothing else to work with, and they came up with these revolutionary ideas, which are normally, much better in terms of thinking about it than what was before them.
Vladimir Yanda, Shirley Sharman, and Carl Levitt, these people treated thousands upon thousands of patients. So Yanda was involved, and Carl Levitt was involved in the Czech coal industry, and he was sort of massive in that area. And you talk about people and you sort of say, well, I've seen 5 or 6 patients with this. These guys had seen thousands upon thousands of patients, and yeah, they had huge amounts of experience.
So
something.
I'm going to have to put on my skeptical hat a little bit,
Okay.
because you're being far too kind of, I'm agreeing with everything you're saying at the moment. But okay, so they saw thousands of patients, but why do you think that why are these posters kind of used so much now, and why is it kind of a standard part of level 3, level 4, do a postural assessment? People still believe that they're making people better by trying to stretch these muscles that are too tight, trying to strengthen these muscles which they think are too weak. They're not doing tests to actually see whether they are tight or weak. They probably wouldn't know how to do so if they wanted to, and often you can't. You say, like, he was using his hands to tell whether muscles. And how is it we all forget about the people who walk in who are like, they've got the posture of that person, for example, in the photo, but they've got no aches and pains at all. They're just coming in because they want to, you know.
Because what we all want a quick fix, and modern society is very much about that. And these, you know, that diagram is one aspect of one approach that these people came up with. They wouldn't take it in isolation. They would go through various different tests. They would go through an assessment. They would develop outcome measures. They would test and retest. So when you look at something like that, it would be the equivalent of saying, what does an osteopath do? Oh, he manipulates the neck. That's all he does. Well, or she does. Not the case. What does posture represent? Oh, it's just that one diagram, and it is not the case that that is going to give you all the information that you require. So if you looked at that diagram and you said, well, okay, what we're going to do is we're going to correct your posture in inverted commas. We're going to stretch those muscles and we're going to strengthen those muscles, and you know, we're going to change you. So firstly, the implication being that you're broken. That is incorrect. Secondly, that there is something wrong with you, and therefore there's an element of guilt that you should have. That is incorrect. And then that we can change your posture, and that is not the case. Now, Yander famously said, if you can affect somebody's posture by just 5%, you will be clinically relevant. So he was sort of saying, well, you can just reduce the tone a little bit, increase the strength a little bit, and that will probably be enough to target the patient's symptoms. And frequently those symptoms were pain. So he was under no illusion that you could take that person and correct their posture, because to correct implies that there's something wrong, and we know that there isn't. That mammals are adaptable, and you can adapt to so many things. You know, you can look at an Olympic athlete who has exactly that posture, and there'll be a fantastic shot putter or discus thrower. So that only becomes relevant if it's a driver to a person's symptoms. So if you look at that and you say to somebody, well, you know, the person comes in and they say, well, I've got horrendous headaches, and you look at that posture and you say, clinically, I need to make a decision. Is that relevant to their symptoms? So, you know, can I change something and reduce their symptoms? Can I reproduce their symptoms by altering certain alignments, for example? And if you can, that's relevant. If you can't, throw it out. It's a bit like saying, well, you know, I've got a sore foot. Well, perhaps it's the stone in your shoe, but equally, it's not likely to be the stone under the collar of your shirt. It has to be relevant to the patient.
That's good. That's very nice. I'm going to turn that into a soundbite. That's lovely. Okay, so I'm still going to try and push you into a corner, but I know it's not going to work because you're a black belt in jiu-jitsu, so you're used to getting out from that sort of attack.
That was a long time ago.
But okay, so are you prepared to say that we shouldn't be talking about bad posture?
Yeah, I don't think we should be talking about bad anything. You know, words have power, and you know, I can come up with infinite numbers of examples of where patients have been disempowered and where patients' conditions have been made worse by what they have been told, or how they've been misled. And it's not so much what you do, it's how you do it. You know, if you want to assess somebody's posture, go ahead. But the way that you're doing it, if you are in, and this is not just therapy, this is in the exercise world as well. So for exercise professionals, if you're implying that somebody is at fault, if you're implying that it's somebody's fault, that they've made themselves, they've made this condition themselves because of their error of their posture, you're going to make them worse. But equally, you could say, well, look, you've come to me and you've said you've had a scan, and the scan was completely clear, but it showed a little bit of wear and tear in your neck. You've got these headaches, but I think that if we can strengthen these muscles, you may improve, because your body is able to heal itself. And once you start to do that, and once you start to see those symptoms improving, the patient is then empowered. They think, okay, it's something I can do for myself. Whereas the contra to that would be to say, well, I can't do anything because I have upper cross syndrome, because I have a flat back, because I'm unstable, because I have a poor transversus abdominis. Woe is me. There's no point in me trying because I have that fault. So it's the way that it is done. And I come across this every single day. I've come across it today, every single day, with a patient who has been disempowered by the way the treatment has been given to them.
It's gonna be tricky, isn't it? I'm just basically falling in love with you a little bit with this conversation. I'm going to try and trap you. I'm gonna make you admit now on record all the kind of things where we shouldn't be doing this about posture, and then eventually in about 30 minutes time, I'm going to say, so when does posture matter? But I'm not going to do it yet.
Yeah.
I'm not going to do it yet. No, this is great stuff. I hope people are listening to attention, and don't forget, if you've got any questions, people, then obviously, I mean, if I was in there, I'll be asking a bunch of questions at the moment, but reach out, because this gentleman knows his stuff, and he's been around a long time, and he's evolved a lot. So do ask questions. So what about words like kyphosis and lordosis and scoliosis and all these kind of like abnormalities? You're saying we should note an assessment, but we got to approach it a different way. The way we, one, as therapists, link that to the cause of the pain, and two, mentioning them to the patient, I suppose, or the client, and kind of.
Yeah. So those are, a medical diagnosis. So scoliosis is a medical diagnosis. However, what we can say is that could be structural or it could be functional. If it's structural, well, orthopedic surgeon's going to deal with that. But if it's functional, if somebody is simply pulled out of alignment by the way their muscles are working, you need to refer them to somebody who knows something about muscles. Now, there's an interesting case that many years ago, my courses have evolved. Many years ago, I used to run a course called Back Stability and Muscle Imbalance. And part of that course was to do with postural assessment and posture changes. And I had a young physiotherapist on who said, well, I have had, just let you know at the beginning of the course, that I've had a scoliosis, and that's what made me go to physiotherapy, because I had a Harrington rod, or they considered putting a Harrington rod in my spine, which is a particular way of treating the spine, or was more of a popular way of treating the spine. And this was a 3-day course. And we went through and we assessed various different postures, and she did several of these different exercises. And she came back it was a 2-part course. So she came back after the first weekend and second weekend. She said, this is the first time ever in my living memory that I can remember that my spine has been straight. And she said, well, I think, nobody has said to me that it could be structure or it could be function. Nobody's ever taken me through that. And yet I feel that I am improving and that I have changed the alignment of my spine. And, that is something which I think is important, that it's easy to play these things down. And it's easy to say, no, the research shows that posture is not relevant to blah, blah, blah. And that's absolutely the case. And I can rattle off things that it's not relevant to headaches, it's not relevant to shoulder impingement, etc., etc. But within each of those groups, there will be individuals where it is important to them at that moment of their clinical condition. So you'd say, well, okay, we can say that low back pain is not correlated to posture. We know that. But for one individual in front of you at that moment, their low back pain will respond to a postural intervention, whatever that may be. Now, that postural intervention may be, we just go out for a walk. You've been sitting down, bent like a banana throughout lockdown. Just go out for a 10-minute walk every day. That's a postural intervention. You have changed the sensory input so that they can alter their alignment, if you like. And I've done this all the time. I treated a guy today, discharged him, never seen him, never met him. It was all online. It was all virtual stuff. And he couldn't work because of postural pain as a result of doing his job. He was a computer programmer, and obviously he was working predominantly on computers. And when it went down into lockdown, that's all he did. But we took him through a series of programs. Now, I never said to him, look, back pain is not related to posture. I didn't quote the research. That wouldn't have been a human thing to do. But I gradually took him through a process where he could come up with that realization, rather than simply violating somebody's beliefs. I accepted it. And, he sort of said, oh, well, I've had back pain and I've been told that I've got a poor core. Now, I could have said to him, well, actually, that's not related to your back pain at all. But there's no point. It's a bit like saying to a child who falls down and bruises his knee, oh, well, you'll be fine. It's not broken. Well, yeah, but it still hurts. I've still got a great big bruise on my leg. So I think it's important that we consider the way that the body moves, and as part of that will be the orientation of one body segment compared to another, and that is what posture is all about. Now, unfortunately, posture has become a plumb line, and as soon as you mention posture, that's what people think about. And really, that isn't what it's all about. It's all about how the body works in a particular time and through a particular series. And posture may not be relevant to back pain to some individuals, but it may be relevant to somebody who's doing heavy lifting, for example. You might sort of say, well, if you change the way that you are lifting, your lift may be more effective, more efficient.
I want to step back a sec, because I saw something which I think I'm going to take issue with.
Uh-huh.
So postural intervention for me is like where you have blamed a particular static posture on something, or you're saying this pain you're experiencing is because of this particular state of your posture when I've lied you down or stood you up, and now I'm going to do something to change that posture, and now the pain's gone. But you kind of used the example of taking someone for a walk. Now, obviously, by walking, you've changed their dynamic posture and the way they're holding themselves. But I don't know whether that's stretching a bit, saying that's a postural intervention.
Oh, I think it is. It is. It's not permanent. We're not changing anything permanently, but what we're doing is we're saying you have overloaded your system by spending too much time in a flexed posture. So we are going to spend some of that time in an extended posture. So all we are doing is changing things, and it may be the opposite. So you might sort of say, well, look, you spend so much time walking that you're in pain. Just sit down, and we're doing the opposite. Now, in terms of the way that things were once sold, if you like, that would be a mirror image approach, a mirror image exercise. But we know that tissue responds to overload, but it can also respond to both underload and excessive overload. So, if you go and do a bench press and then you rest and you do it again and you rest, eventually you get stronger. But if you don't lift heavy enough, you're not going to get stronger. But equally, if you don't rest long enough, you're not going to respond. So, the intervention is important, but the recovery is important as well. And what we're doing there is allowing the system to recover, to to sort itself out. And one of the things I put up in my in one of my lectures is a little comparison of a car with 3 wheels and a dog with 3 legs. That, when the car loses a wheel, well, it's not going anywhere. But when the dog loses a leg, initially it can't do anything, but eventually it can adapt, and it can thrive. Now, we're not machines, so we can adapt and we can thrive. The question is it the adaptation which is incorrect, and is that what we're managing, to try to target that person's pain?
So you were suggesting this person's case, the fact they were sitting down for too long, they were in a flex position for too long, and the act of walking was introducing them to a more of an extended position. But that, how are you so sure that their pain was due to sitting down for too long, being flexed, when you've got other people coming in who are sitting down for ages and not in pain? Because for it to be an intervention, you've got to first say that it's the causation. So that's the problem.
Well, not necessarily. Causation at that moment, yes, but it may not be long term. But what we're looking at is symptom modification. So if a person's in pain, I need to be able to do something to reduce their pain or reduce their symptoms. It may not be pain. And once you've found that, you're going to lock into that in terms of your symptom modification. Now, that's not to say that that's the only thing you would do and the most important thing, but it's to say that that is important at that moment. So if they're in a reactive phase of an injury, and you say, well, if I can modify something, you're in pain, so stand up. Does that reduce the pain? Yes, it does. Okay, let's keep doing that. And once that's happened, it's a sales pitch. So you say, well, okay, that's reducing the pain. I could give you a bottle of paracetamol. That would reduce the pain. I could hit you around the head with a wet kipper. That would distract you, and that would reduce the pain. So all we're doing is we're using your body's own pharmacy to reduce its own pain. How clever is that? What we're then going to do is, once that has gone, we're going to do something else. So I'm not saying to you, to the patient, you need to do this movement over and over again all the time, and that's it. What I'm saying is, at this stage, you do this. And the analogy I give to patients is, look, when you cut your finger, it's bleeding. Let it form a scab and then move it. Now, if you move it while it's bleeding and it doesn't form a scab, it's not going to get anywhere. Equally, if you don't move it, once the scab has fallen off, you're going to end up with a stiff finger. So we have to parallel the stage of healing. And this is the approach that I use in my 3 R's approach to back rehab, where I say, it's a reactive phase, you've got a recovery phase, and then you've got a resilience phase. And you're trying to target your treatment to that particular phase. And it is targeting the treatment to the person, not to the tissue. So we might be saying we're working on muscle. No, you're not. You're working on somebody's skin, and there's muscle underneath. But that whole thing, the skin and the muscle, is inside the shoulder, and that whole shoulder is inside a person. So whatever we're doing is biopsychosocial, whether we like it or not. It's just that sometimes we don't admit it.
I like it. Okay. So the act of getting to stand up and walk,
Yeah.
I can see you are not necessarily just associating it as a lengthening of the hip flex or something. It's the whole thing of the brain receiving different sensory stimulation and the biopsychosocial side of things. And then, I like it. Yeah. Yeah,
and depending on who you were, you could argue, couldn't you? You could have some person there and saying, right, well, I'm into muscle. This is what I think walking's doing. You could have a psychologist and saying, this is what I think walking's doing. A sociologist, this is what I think walking is doing. And they would all be right, because they're all dealing with the person, but from a different lens.
I can't believe I've met someone else in 10 years who's also using the wet kipper. I thought I was alone in that, but I often use that where I say I could go in the garden and slap my bare buttocks with a wet kipper and it might start raining, but I mean, I didn't actually cause it to rain. It's nice to meet you, fellow kipper enthusiast. And you've definitely tickled a few people in the listeners as well. So is this a million of miles away from the therapist who therefore starts trying to stretch the hell out of the hip flexors because they say that's the source of your issue because you've been sitting down too long, which happens a lot, and we've got loads of videos of how to stretch your hip flexor, and it's the first thing they'll like.
It comes down to clinical reasoning, doesn't it? Are you know, what is it you're trying to achieve? I'm so the therapist says, I think I'm stretching the hip flexors in order to correct the alignment of the pelvis. So what has the patient, that's fine. You've intended to say that because you think, well, that's a good thing. You know, I think it's something I can modify. That's not what the patient has heard. The patient has heard, there's something wrong with my hip flexors. They are tight. That's something I can't do anything about. Now, in order to do something about it, I've got to go to this therapist because he or she is the only person who can fix me. Now, so what you've intended with your treatment has not been what is received. So you've intended something positive, and actually they've achieved something negative. And so you've got to be, we've got to be very careful with this. You could equally argue, well, we know for a fact that if you're stretching somebody's hip flexors, the chances are you're going to achieve nothing in terms of the physiology. Now, you might change the tone of the muscle, or you might be instrumental in the patient changing the tone of the muscle. You know, as a therapist, you're not going to do it unless you inject something into them. But what you can do is encourage them to, you know, hold their hand, as it were, to encourage them to go through that process. And I think it's a sales pitch of what you do. We could have 3 therapists all targeting that pain in different ways. And there are many ways to skin a cat, as they say. Providing the outcome is one of improvement, we could turn around and say, well, the treatment was correct. The danger, of course, comes when you lock somebody into a treatment thinking you're doing some good, when in actual fact you're not. And I've come across this, and other sort of therapists who've been in the game for a long time will be able to tell you hundreds of times where people have been inadvertently misled. To not just some therapists, you know, people have had scans, x-rays, you know, different things where they, you know, for years they've thought, well, okay, that I can't do anything about this because that scan shows I've got an osteophyte which is pushing into this, or because that scan shows that I've got something which is not in the right place. And so they've never bothered to go further than that. And that has disempowered the patient, and now actually is causing their problem. So it's the belief which is causing the problem, but the belief at the time was from a practitioner who was well-intentioned, but it has gone on and on and on. And let's not be, you know, let's not be wrong about this. That can be very serious. I mean, I have someone in this area, in my geographic area, who had a relatively simple shoulder pain, was given opioid painkillers, and that was well intentioned, I'm sure, at the time. But unfortunately, the prescription was never caught up, and it was repeated and repeated and repeated and repeated. And the girl was young and didn't know anything more, and she went into liver failure and needed a liver transplant. So, you know, these things can happen, and it could be that, you know, the very time you're pressing into somebody's back and you say, well, yeah, I think that's through that tight muscle that you've got, and we need to really get rid of that. And you never see the patient again. Patient doesn't come back. And so they go through their life thinking, I can't do this because I've got a tight muscle. I can't play with my kids because I've got a tight muscle. I've got to change my car seat. I can't have that type of car because I've got a tight muscle. And what is simple to you as a therapist becomes something which is complex and limiting to the patient. So we've got to be very careful. Words have power, don't they? And as do actions, therapeutic actions.
Excellent. Yes, it's very much touching on what Mike was saying last week, with the power of the language we use and the posters we've got up and the associations we make. Okay, so we're very much on the same page, and I think quite a lot of people in here, looking at the names of the people in here, are as well. But something's going wrong, isn't it? I mean, you've worked with different educational organizations. It does seem that the way traditionally we've taught this is we'll give them a structural reasoning first of all, where we just get people on level 3 to look for lordosis, kyphosis, mark it down, one shoulder higher than the other, and straight away we're educating them to treat the body like a car, which is complicated, but as long as we follow the right kind of like book. How are we doing it wrong? Do we need to really start anatomy with consciousness of the brain and then add the structure? Or
you've got to give a student a model for them to go on. You know, if you make a cake, you need a recipe. You've got to give them some sort of model, but you've got to make sure that that model is based on sound evidence at the time. So when I qualified 40 years ago, if we were asking a question in class and the tutor didn't know the answer, they would say, I'll ask the principal. I'll ask the principal of the college. So there was no evidence, there was no research. Now we've moved on from that. And nowadays you should be able to, you know, to justify what you're doing from the evidence, and that evidence will be research predominantly, but it can be clinical practice and patient experience as well, but it predominantly research. So we need to make sure that what we're teaching is research based. Now, I would suggest that observation is important to a student. Giving them a structure to that observation is important, but postural analysis and identifying a postural fault is probably not the correct way of doing it. So by all means, observe the body in movement and observe the body statically. But if you're hanging your hat on these terms, which, 30 years ago were relevant, perhaps you've not kept up, and we're all guilty of that, and I think it is important. When I wrote a textbook many years ago called Back Stability and Muscle Imbalance, and within that textbook I look at that now and I sort of think, well, at the time that was great, that was fantastic. And then I went on and I did some research and got my PhD, and the years rolled on, and I look now and I say, well, actually that's not particularly useful nowadays. And in 20 years' time, I'll probably look back and say what I'm doing now wasn't relevant. But you have to chop and change with the times and with the evidence. But at the same time, that evidence has to be balanced. And I think particularly on social media, it's black or white. And clinically, it's not. It's grey. And so we've got the anti-posturites, we've got the pro-posturites, we've got the anti-manual therapy, the pro-manual therapy, we've got the anti-hands-on, and all that does is confuse students, confuse patients, and give you imposter syndrome. And you sort of think, I'm not good enough at my patients because I didn't know that reference that person put up. I hadn't come across that one paper. And so you beat yourself up about it. And I don't really think that does anybody any good. Gets you lots of likes and shares and different things on Twitter and Witter and Pitter and all whatever else there is. But I really don't think it is good for the profession. I think we shoot ourselves into the foot by being so critical about what we do all the time. And ultimately, it's the patient who suffers because we're not confident in what we do.
Yeah, it's interesting. But I think we do need to, I teach level 3, level 4, level 5, and even on level 3, I'm having to interject each time I go, ding, another moment where you're going to have to tick this for the exam, but it's not quite true. And I kind of think, most people who teach will know that the whole syllabus needs some radicalization quite a lot. I think we should start off with, right, what is a person? Okay, it's the brain, and then start off looking at the nervous system and the effect of everything and sensory input before. When I teach A&P, I try and start off with that, so people realize that although we're talking about the muscle does this and the joint moves in this way, it's only because of the governor at the top. Okay. And so when we get into talking about when things start going wrong, already kind of students are thinking, oh yeah, but what about the guy at the top? How's he involved, or she involved, or it involved,
Yeah,
but we don't do that because it's complex, isn't it?
It is, but essentially we are trying to study surgical anatomy, and we're not surgeons. So, we're looking from the inside out, and I think to observe the body and to come more from an exercise perspective can sometimes be useful. But I think within sort of translation, sometimes that gets lost. And I'm a great one within therapy of intuition, and sort of saying to a student, well, you know, what strikes you between the eyeballs of that patient, never mind the books and things, what do you as a human being see when you look at that person? And sometimes intuitively you will be able to find something, and then you can guide along that line and say, well, you know, they seem to be walking in a funny way. Well, okay, let's have a look at that. And a 5-year-old might be able to identify that and say, well, they just seem to be walking funny, or they seem to be standing funny, or they seem to be doing an odd sort of twitch with their shoulder. Okay, well, let's go down that route and see if we can investigate that. Because you know, if you come straight down to bones and muscles, you end up focusing on the minutiae, and you're treating the hip flexor, and actually you miss the person.
Okay, right. I'm going to start looking at questions in here. I'll just remember there's a few people watching this as well. So we'll have a look through there. Just kind of a summary for people watching this. I always try and guide this, like I say, to people who maybe have just maybe a few months out of passing their level 3 or level 4 qualification. You've done your postural assessments. You've been marked on this. Maybe even in your case histories, you've had your tutor saying, oh, yes, but what does that mean if they've got one shoulder and they're higher? Yes, we need to balance them out. So they need to be level. You're probably hearing stuff which is contradicting that. But one of the lovely things that Chris and other guests have done before is we're not saying you have to throw everything out. As the expression goes, you don't have to chuck the baby out with the bathwater. It's just tweaking. We still look at these things, but we don't forget that behind every single one shoulder higher than the other or lower than the other, there's a emotional rationalizing brain. We've got to keep that into consideration with regards to what we jump at as the source of the pain, or what the person listening to us as we walk around with our clipboard going, oh, that doesn't look good. Doesn't work. Yeah, we're not mechanics. So let's look at some questions here. I've seen some lovely comments coming from you.
Yeah, there's a couple of concerning comments there.
Oh, go on.
And that is people saying, well, I feel, there's 2 or 3 people saying, I feel that I've got imposter syndrome and I don't feel confident in the profession. I don't feel that I can go on. I think you've got to look at a patient and say, well, if not you, then who in terms of the treatment? So if somebody's come to see you and they are in pain, you might sort of say, well, I'm not the best person in the world to treat that individual, but I'm all that they've got at the moment and I can improve them. And that to me is a good therapist. The one who's not good is the person who says, I know absolutely everything and I'm better than everyone else. If you're feeling insecure and you're feeling doubts, you're a good therapist. So I really wouldn't beat yourself up too much. You know, none of us know everything, and there will be never a time in your career when you can sit back and say, I know everything. And if there is, stop, retire, get out of the profession. You know, we're constantly learning because we're interacting with human beings. So, you know, imposter syndrome is important in that you doubt yourself, but that drives you forwards and that makes you a good therapist.
Yeah, we've had a few people in there mentioning that. Emily Bryan, just people listening to the podcast, Emily O'Brien says, I also struggle with imposter syndrome as massage is my second career after being a dancer my whole life. But it's like, it depends where you feel that your skills are. If you put your skills in your hands and you think that you have to massage lots of people with your hands to get that skill, then yeah, maybe you think you're inexperienced. But when you become a therapist, you're looking at your skills maybe from when you were 3 years old and you picked up the ice cream with the person next to you because you felt sorry for them. It's more of an empathy thing, isn't it? It's about wanting to care for people. You're not using just your hands and your elbows, are you?
I would suggest that Emily can see things in individuals as they move that others probably can't, because since the age of 4 or 5, she's been looking at people moving.
There you go.
So you play.
Yeah. So I think you're only an imposter when it depends on how you judge your skills. And, you know, when you look at yourself with a different pair of glasses and you realize you've got so much to help people, especially through COVID. I think some therapists, hopefully a lot of therapists will come out as better therapists thanks to COVID, which sounds weird, but because you will be looking at much more at the subjective, considering the person at the end. And you've gone through a traumatic experience yourself, which often helps. You know, you'll be interested in how someone feels.
The public will be more open to the power of touch and the importance of touch and human interaction. You know, so I'm not suggesting that we required COVID to do that, but certainly I think it is something which is important and has perhaps now risen to the top of you know, a bit like the cream in the bottle, really. And a lot of the press are talking about this and saying, well, we miss human interaction, we miss touch. And you think, well, yeah, we've been saying that for years, but now others are confirming it.
Yeah, that's very true. I liked, as always, every week we have a nice comment, or quite a few comments. What does Becky say here, which caught my attention? Oh, there we go. Becky Carroll put it, I think we need to be comfortable as therapists to acknowledge and embrace the fact that we are dealing with educated guesswork at best, hence why it's so important to keep up to date.
Yeah,
yeah,
I would
nice,
agree.
isn't it?
Yeah, and there's a lot of trial and error. There's a lot of your intuition, and there's a lot of trial and error within therapy, within all forms of medicine. It's just that within therapy it becomes more obvious. You know, if you're a doctor, you know, and you're giving a prescription, there will be an element of trial and error in how much tramadol you give. So you know, it's just not as obvious as perhaps it is in therapy.
Fantastic. Right, so be thinking of other questions, people. It's 8:50, so we've got 10 minutes left if we stick to schedule. What about, I mean, sometimes I like the way you've said, especially social media does turn into a polar debate, and it doesn't really help anybody. What about now and again posturologists?
Yeah.
Are you familiar with them? It's a very old kind of around the same time as original.
To that first back, I mean, there are some negatives about social media, but there are also a hell of a lot of positives. I mean, you can get a lot of education for nothing from social media. So, you know, and certainly COVID has shown us that, you know, that research can be so quick to be shared. Lives have been saved by social media, no doubt about that. Posturologists, I mean, I think it's like anything, isn't it? You can take one element of any profession and make it into a profession. You know, you could have an injector therapist or an eyeball therapist. I suppose that would be an optician. But yeah, so and I think the danger of that is that you medicalize something, which is how posture really developed. I mean, if you look at the history of posture, it became medicalized and it became something that was important medically in the 1920s. Prior to that, it was just, well, it was just to do with good and bad posture and what dress size you took and how you stood in a regiment in the army, and you know, sort of the Ling Swedish gymnastics school and all these types of things. So it then became medicalized. As I suppose we could say that massage became medicalized and exercise became medicalized. You know, it's how you sell it to the individual. But I think you've got to be cautious that, you know, we've got a whole list here of good therapists who are feeling insecure, but you've got a lot of people out there who will say, yeah, by doing this, I can sell this person this chair or this back support. And if I tell them that their lordosis is wrong, they'll buy this, that, and the other. So, you know, the flip side is that you can use this or any type of approach as a money generating scheme.
Yeah.
Be a bit careful with that.
You can pay to pathologize. I can't remember who said that. I'll give you credit to it is, but it's a nice way of looking at it. And we've got to be aware of that. Anything that simplifies down enough, and that's what it is. It's making something very simple and attractive to us as therapists paying for CPD courses and to patients receiving it. So, but I like what you said about social media. It's true. And there's a lot of positive stuff that's come out of it as well. Becky's come back with saying, for example, if it weren't for social media, I wouldn't have found the STA in my hour of need. See what I mean? You can see what sort of person we're talking about here. She definitely comes out with it. Oh, something in my eye. That's it. Got So tell me a little bit about, I mean, now we've never actually talked before face to face. I think we've coincided on various conferences and things. But so I'm really interested in your courses now, particularly the one which is about posture and when does it matter. I feel like I've got a much better knowledge of listening to you for the hour, but anything else unique about your course which you'd like to mention or talk about?
Yeah,
That
so
one?
I run dozens of courses, face-to-face courses, but I've also got some which are online. And so what I've done with the posture pain and therapy course is essentially to put the posture side of things online. And it goes through a whole series of different tests and clinical reasoning with patient demonstrations and with subject demonstrations. And my aim really is so that the therapist can go through piece by piece, and they can look at the technique again, and they can perfect that for themselves. And they've then got some more skills in their treatment toolbox. And what I've done is to try to, on that particular course, to throw it open and say, well, okay, it might be physios, it might be osteos, it might be massage therapists, it might be personal trainers, it may be Pilates teachers. There will be an element within that course that would be helpful to you in that profession. So it's quite an extensive course. We've got about 80 lectures on it, and some of them vary from lectures with slides to lecture demonstrations, to video demonstrations, to interventions, and these types of things. And there's manual therapy, and there's taping, and there's all sorts of different things. So what I've done is to say, well, okay, on the one side, let's take the research. On the other side, let's take the experience and the things that I've found over the years that work, and let's put them together. And it seems to be working in that it gets good feedback, and people say nice things about the courses, And I've got a number of these courses, but in terms of the posture one, that is the important one. The other one that I run is the back rehabilitation 2-day course, which is a 3 hours approach, and that some of that is online simply because I've been teaching it to some of the universities online. But essentially, that's a 2-day back, face-to-face course where we go through all the research, but we go through all the practical stuff. And again, the beauty of that is that I get therapists and exercise professionals all working together, learning from their own different skills. So where we've got that example, we would use somebody with dance skills to say, well, okay, this is how you do it, to the physios, and the physios would say, well, this is how you can do a simple manual technique if you're a personal trainer. And so what I'm trying to do in the 3 hours approach really is a clinical framework. So rather than just teaching you things, it's drawing out your individual skills and putting those together. So those are the two parallels, I suppose, the two parallel courses that I have, which involve posture and postural interventions.
Fantastic. So for people listening to the podcast and can't see what's on screen, then the website to go to is norrishealth.co.uk, and all details of that are up there as well, as long as a blog and various resources, which I recommend you take a look at. Have you got plans I suppose being a physiotherapist yourself, you've been able to see people face to face, but are there plans for any of these courses to go face to face once that's allowed?
Yeah.
Or
so yes, we're in the clinic all the time in PPE, which is a bit of a pain, but there we go. Yeah, so the courses, I think I've got a face-to-face course in May on the back rehabilitation. That's in Derby. And that's run through NCORE, who are a particular organisation attached to one of the Derby hospitals. I've also got quite a few face-to-face courses on other subjects. I do some teaching on acupuncture and dry needling, these types of things, and those are going ahead. At the end of March, I think, is the first one. So they're gradually sort of waking up again. And those will go out through the summer. And what we've done is to cut the numbers down, make sure that we've got good airflow, make sure that we've got PPE, and just as the universities are doing at the moment, sort of making it safe, but also making so that people are confident to do it. So you want to be able to relax and not be conscious of what you're doing. Becky's telling me that she's done my dry needling course a few weeks ago.
Yeah, you got quite a few supporters in here tonight. They're speaking very fondly of you. And Nicholas Smith as well says that she went to a 2-day back care course with you. It was great.
Brilliant.
Very interactive, and like you say, therapists from various backgrounds.
Yeah.
It's an interesting time
as well, that when you've got people from different backgrounds, it's really great. It makes it more interesting for the tutor.
We've got, I mean, it's an interesting time for CPD, and I think therapists are going to have to be careful, because once conferences are allowed to happen again and over 100, 200 people, whatever, are allowed to meet up, I think, well, those of you who've got some money put away, because I appreciate a lot of you haven't got any money at all, but as therapists, I think there's going to be this danger of, right, I need to start educating myself again. I've been off for a year or something. And so choose your CPD wisely. If it makes any easier for you, just go through the guests I've had on this podcast and just pick them out. Just choose what you like the look of. I can personally vouch for people who've been on this show, but I think it's a dangerous time, because I think, like you say, the healthy CPD, like yourself and Mike Stewart and other people we've had on here, Claire Minshall, etc., is there, but there's going to be an opportunity for other less, should we say, evidence-based forms of CPD to get out there as well, with massive marketing things they've been planning, and they'll hit the social media. So
it's a difficult world to filter through if you're a student, because
very difficult.
You know that a course is bad until you've been on it.
Let's we're talking about posture. We'll finish off with a question from Lisa Reynolds then, if that's okay with you. I'll bring it up on the screen. That's one of the joys of joining us live. Lisa Reynolds says, does how you sleep affect your posture, seeing as how long you spend time in it? How would you change that if you think it was affecting someone presenting with pain at the shoulder?
I think it can be related to it. Certainly the way that you take up your sleeping posture, but we can also look at posture from another perspective. We talk about biopsychosocial approaches, saying, well, when we're talking about the mechanics of muscles and bones, we're talking about the biological, but we've also got the psychological and the sociological, and certainly sleep would be something which is coming into recovery and the psychology of it. And a person who is getting better sleep and is less anxious, less depressed, is more likely to have a more upright posture, and vice versa. So what we do know is that through sort of general embodied cognition theory is the big thing, that the way that your thoughts can be exposed, if you like, by your posture, and vice versa. So if somebody's very depressed, they will tend to go more into a fecal posture, and if they're more confident, they'll tend to be more upright. And we find that particularly with adolescents, for example. So I think there is a relationship between those two, between posture and sleep. I don't think it's necessarily a causal relationship, but it's certainly an observed relationship.
Definitely, yeah. There's some great points there, and we could have talked a lot more on the whole relationship between posture and emotion and stress and anxiety and worry. But I've had people persuading their partner to sleep on the other side, turning their beds the other way around so the window's on the opposite side. Sometimes you have to go to change the whole bedroom around just so they can happily sleep the other way around. But any change to the body is going to potentially desensitize an issue, isn't it? A pain issue, and get them experiencing different stuff.
Change. So you can say to people, well, look, just for 2 days, sleep sleeping on the bed until you can find that your pain is slightly better, so that you can sleep through, and then you can move back together. It doesn't need to be permanent.
Fantastic. So, right. Thank you so much, Chris, for your time. It's been a great hour. I can't wait to listen to it back myself. I hope everyone in here has gained some information. And if you are interested in Chris's courses, then make sure you do go to the website. We'll put links up in the comments so that you can go there directly. Next week, same time, same place, we're going to be talking about, if I remember rightly, hypermobility. So another great topic, which is related to posture, I'm sure. Everything is. So yeah, do join us next week. Chris, thank you so much for your time.
No problem. Nice to see you.
If possible, and we're going to have to start doing these soon, there's always such a demand to have people back, because we try squeezing it all into an hour, but maybe in a month or 2 months' time, we'd love to have you back if you're available and free.
Yeah.
No hopefully by then some people have done your course and they can talk about them as well.
Yeah.
Right. Thanks, people. Thanks for joining us again. Thanks, people listening to the podcast. We'll be back next Tuesday at the same time at 8 o'clock on the Sports Therapy Association podcast. Take care.
All right. Cheers, guys.